So firstly, I'd like to invite Tim back up to the stage. Thanks, Tim.
Thank you very much. So thank you very much for the invite to be here today, and I'd like to echo the acknowledgement of country to Ngunnawal people in which lands we meet today. I've come from the lands of the Eora people in Sydney, where I have the privilege to live and work. So I'm going to talk about this topic, which I appreciate for some of the questions, a little bit controversial, and that's good. I'm going to talk about some changes and also spend a bit of time on the rationale for those changes as well. So let's go. I'm going to start actually with the take-home messages. So if you remember, this is highlighting what the actual changes are in the guidelines, and this has been said already, so it's a repeat of what's hopefully you've taken in already. But tobramycin is now included alongside gentamicin for all indications, except for when it's used in synergy for endocarditis for the Streptococcus and Enterococcus organisms. Gentamicin and tobramycin now are equally ranked for infections that are not caused or likely to be caused by Pseudomonas aeruginosa. I'm going to show the data that supports that as a safe practice. Tobramycin is now ranked first line and gentamicin second line for infections caused by or likely to be caused by Pseudomonas aeruginosa. And I appreciate this is probably the one that's most controversial, but I'm going to show some of the data about the reason that this change has come about. So I think it's good to remind myself and the audience that we practice with these antibiotics very regularly, and there are terrific advantages of the aminoglycosides. And when we discuss these antibiotics, there's lots of reasons to keep them in our national guidelines, and we've heard today other international guidelines have maintained them as well, notwithstanding we've heard there's an argument published recently against them being used at all. But aminoglycosides rapidly kill gram-negative bacteria quicker than other antibiotics that are put as alternatives for upfront therapy. They're effective against many resistant pathogens, including the ones at the hospital onset in Australia as well. Once daily dosing is very attractive for these antibiotics in our system for nursing time and plastics use, environmental reasons. There's a very low allergy risk with gentamicin relative to other antibiotics as well, which is attractive. And people know they're rarely associated with C. difficile infections compared to other antibiotics that are a broad spectrum and other international guidelines promote upfront as sometimes as alternatives. I think there's the disadvantage we all know too well, and sometimes I catch myself focused a bit too much on these because I appreciate these are actually quite rare in our clinical practice, and often when we see them we can look back and say, oh, an error has occurred in the system where these occur. Not always, but often there is. But they can cause nephrotoxicity with extended use and high dose, and this is usually reversible. But they can also cause vestibular and auditory toxicity with extended and high dose, and this is often irreversible and one of the more devastating ones if you've had patients with these complications. I'm going to show some of the data quickly around the gentamicin and tobramycin activity against Enterobacterales and why it's reasonable to put gentamicin and tobramycin together. So some of you recognise this is a free resource from UCAST that you can get looking at some of the rationales for antibiotic use and dosing. And what this graph shows is a few things, but looking at the bar graph first, along the bottom you've got the MICs for gentamicin and tobramycin, and then there's two boxes, orange boxes and blue boxes. Orange boxes is a collection of organisms, of the standard organisms that are set for UCAST, and they've got the distribution of the MICs, which cause that nice bell curve to the left. And the blue organisms, the international organisms, the Century collection, and internationally the organisms that reflect the similar MICs. And this one, these groups to the left for gentamicin and tobramycin, we call this the wild type because there's no resistant mechanisms for these organisms. But you can see to the right there's a small number of these that the graph at towards the right with MIC greater than 16, greater than or equal to 16, where there is some resistance. The red line is looking at the attainment of targets and the ability to suppress the growth of the organism. And you can see for the MICs that the target achieved for both gentamicin, the red line, and for tobramycin, the red line on the right, is achievable for organisms at 2 or less at very high percentage. It's a percentage probability that's attained using a thing called Monte Carlo simulation that I don't know many in the room will be familiar with, but it's a statistical model looking at how we can achieve, how often patients can achieve these targets, acknowledging people at different weights, have different volumes distributions and whatnot. And so we can see here that for both tobramycin and gentamicin for Enterobacterales, we can achieve it for the MIC of less than or equal to 2 very easily. So these ones are interchangeable. There's, we talk about tobramycin being better, but for some organisms, gentamicin actually has the lower MIC, things like Serratia mycescens, for example, not to the point of being clinically significant, but you remember that it's not black and white. And the mechanisms for this is probably multifactorial, but the main mechanism probably relates to the fact that tobramycin binds differently to the ribosome compared to gentamicin in a way that leads to these MICs being slightly different for these. But globally, for Enterobacterales, making the point that it's very similar for these, and it's very safe to use them interchangeably. Ed's already put up the slide to the left there, which is the E. coli rates of resistance to gentamicin. I've included the Klebsiella pneumoniae she referred to, which has much lower rates of resistance in Australia, and the other Enterobacterales, which I've not here, are also very low. The issue around this is many of you know that this is being driven by ESBL, not that ESBL confers resistance to gentamicin, but often genes are co-transmitted with ESBL. So about half or just over half of our ESBLs remain susceptible to gentamicin, but as you see in your clinical practice, E. coli ESBL is much more common, and therefore by inference or by travelling alongside it, we see gentamicin resistance being higher, but still less than 10% for these organisms. And this is blood culture data, so it's the kind of the pointy end of our data in patients in hospitals. So you could argue this is the kind of the ones that are probably a bit more resistant than what we see in the community, perhaps. I think the point of putting this up, though, is that you can look at your own state up here from people in Australia, and there is variation, and so you do need to be aware of your antibiograms locally, and there's lots of discussion around the patient, particularly those who are septic and particularly unwell, about the role of other aminoglycosides pluses, such as amikacin. I'll talk a little bit about that at the end of the talk. So moving to Pseudomonas and the change here. So again, same UCAS document here, and you've got the MICs of gentamicin and tobramycin. And unlike the Enterobacterales, where essentially the MICs were the same across those, looking at the orange, which is the UCAS collection of organisms, and Century, the collection of organisms international, the MICs, if you can see the midpoint there, if you can read it, it's approximately 2 for gentamicin, whereas 0.5 for tobramycin. Significantly different MICs for these organisms based on the drug to do with the binding of the drug to the ribosome and its activity. And then the red line again is looking at the ability to suppress the antibiotic growth by this Monte Carlo analysis, statistical analysis, and it gets uncomfortable with gentamicin very quickly, that if MIC of 2, only about 20% of the time can patients achieve the level to suppress the growth of gentamicin with the doses that are achievable clinically. So if you're lucky and have the highly susceptible gentamicin strain, then you probably do okay. For urinary tract source, you're probably always going to do okay because the drug concentrates there. It probably doesn't matter what the MIC is in many cases. But to make the point that for gentamicin, both UCAS and psilocybin now become at the point where they're no longer supporting breakpoints for gentamicin because we can't achieve those levels. But tobramycin, you can see on the right, remains very highly susceptible to gentamicin and very confident with an MIC of 2 or less that we can achieve those levels for those. And that's the basis of the change of putting tobramycin first, and as a transition we've heard earlier, gentamicin as second. And I think we had lots of debates whether you just take gentamicin out altogether for this, and I'll talk a bit about that at the end. And some people in question, Tom already brought up some of the transition issues related to this change. And I just summarise this data from the agar blood culture susceptibility, just to highlight the point that tobramycin for Pseudomonas, this is Pseudomonas blood culture isolates from 2023 across Australia. I know many of your labs will contribute to this data, but tobramycin is highly susceptible to gentamicin. In fact, more susceptible. We see great susceptibility compared to meropenem, even amikacin, when we look at the Australian data across Australia. So it's a highly active agent for Pseudomonas. It's not used as a single agent. We've heard already, perhaps with the exception of urinary tract infection, UCAS both talk about it being used in combination with either another antibiotic or another procedure such as source control. I love that source control can be considered a secondary antibiotic when it comes to aminoglycosides. But it's to make the point that we've got very good data. This is very safe. And this is a combination of hospital onset infection, bacteremia, as well as community. And just, it wasn't that long ago that CLSI came along with the changes that UCAS had already implemented, and so now they support the change in mid-2023. So just over 18 months ago, they've moved to these lower MICs for Pseudomonas as well, for tobramycin, and they no longer support a breakpoint for gentamicin. So there's still going to be labs in Australia and globally that use CLSI that are going to be reporting gentamicin sensitivity results for a while, because there's a transition period of implementing these things, but that will it's no longer supported when they move to these new kind of recommendations. So that's the kind of background of why there's been the change, and I think in terms of the move towards tobramycin, the second part of my talk, just very briefly, is to talk about another area that already came up in discussions earlier. It's also controversial. I think the therapeutic guidelines is moving, and there's discussions to move further with this. And this is these patients where are coming into hospital where the initial therapy of IV therapy you anticipate is going to be greater than 72 hours, and the option to use a non-aminoglycoside up front. And I think we all come across this now in our clinical practice, patients coming in, we're balancing the effectiveness with potential toxicity. And the example, I think it's best managed with the example, a patient coming in with complicated diverticulitis, you know they're going to be nil by mouth, they're going to be very unlikely to get microbiology results from these patients unless they're septic, expecting a blood culture result, and often they are on antibiotics longer than 72 hours intravenously. And there's now the option in therapeutic guidelines to make a decision to use a non-aminoglycoside regimen to initiate these patients on that, rather than going down the traditional path of the aminoglycoside up front. And I think the benefit of this avoids the need to switch between IV antibiotics at 72 hours. I'm sure you've seen, I see in my hospitals occasionally the gentamicin is given as the stat dose, and then the patient is not given it subsequently, so they end up being on amoxicillin and metronidazole for their intra-abdominal infections and that kind of issue. So we'll get around some of that kind of safety problem we see as well, I suspect. So some of the considerations here, these are patients where you're thinking you're not going to get microbiology results within 72 hours. And I think we recognise it can be practically difficult to know which these patients are going to be when they come into the emergency department. But what they're not the patients where the septic or septic shock, and we don't want to complicate the decision in the emergency department, often being made by JMOs. These are patients that should still go down that path, the aminoglycoside pathway. And it's very clearly stated in the guidelines for that to happen. And we want that to be clearly to have a quick decision, but also for that broad therapy to be given quickly. And I think the other kind of thing this recognises the importance of source control in certain infections. And remembering that aminoglycosides don't work particularly well at low pH. So, you know, a patient with a big abdominal abscess, the aminoglycoside is not going to get into there and work well. But a patient that's got a bloodstream infection, who's got febrile, got a spillover, it treats the blood very well. And then the source control procedure, often when that happens, oral therapy, in my practice, is what we go to very quickly. And so it avoids necessarily having to go to alternative intravenous agents and switching between those. So I think this is a complicated issue. The guidelines are moving towards looking at other kind of indications where this might be a reasonable practice, and as I said, they're always open to feedback. But just kind of summarise in my mind, putting it together, you know, patient septic or septic shock, start the aminoglycoside containing regimen, no delay. Unknown IV therapy duration, which I appreciate is often difficult, but you're unsure, start with the aminoglycoside containing regimen. Likely IV therapy greater than 72 hours, consider that non-aminoglycoside regimen. There's a couple of indications. I mentioned one already, the complicated diverticulitis, where this was something that's now mentioned in the guidelines. And considering that microbiology results may not be available. And where the source control is likely within 72 hours, there's still a preference for aminoglycoside-based regimens. I think there's issues around the spectrum of activity being greater, treating the bloodstream infection quickly with those agents. That's the kind of arguments that came forth in leaving it this recommendation for now. So my last slide to finish up with is just kind of going back to a summary of the aminoglycosides in the guidelines. And so I always struck about how similar these structures are for these antibiotics, yet they're quite different in their kind of activity and what they do. The Enterobacterales activity is very similar for gentamicin and tobramycin. I haven't mentioned amikacin yet. Amikacin, there's no actual guideline, there's no recommendations, box recommendations, formal guideline recommendations for amikacin in the guidelines, but there's some discussion around the text. Those that might be looking at their local antibiograms, particularly for those patients with septic shock, where you're worried about the resistance rates. There's a discussion around the option of looking at that locally. The Pseudomonas activity, I've put a plus for gentamicin. It's clearly not active against gentamicin. We've used it for decades, and I'm sure you've all seen clinical practice where patients get better. But the issue is there's insufficient evidence to support ongoing breakpoints and recommendations for it. The enzymatic activity is very kind of similar, or inactivation similar for gentamicin and tobramycin, but as you know, amikacin is much more stable against that, and hence its kind of ability to remain active. This is local, it's probably controversial data, but this is not it's confidential data perhaps, but this is local costs. I've just put together on the back of the envelope what it costs for a 60 kilogram adult. So gentamicin is about $5 for dosing in my system at the moment, and that's actually expensive. Historically, gentamicin is cheaper than water to buy, and this is based on the fact that there's shortages and we've moved to a different brand at the moment. So you know, that's the current expensive price, and often it's cents rather than dollars. Tobramycin is about double that currently, and amikacin double plus that again. Historically is even more expensive than that, so it's actually come down a lot in price. Someone mentioned already, one of the issues locally when I started prescribing tobramycin, there's pushback from my very sensible pharmacist, one of the hospital I work at, saying, oh, this is painful, we have to put it in the fridge, you know, we can't keep it on the shelf like we can gentamicin. So there's this kind of teething issues. Those have sepsis trolleys perhaps with your antibiotics on it. You should think about how you're going to implement these changes in terms of having those antibiotics available for patients with sepsis. I don't know all brands of tobramycin require a cold chain, but some of them certainly do. And we mentioned already that not all labs have ability to support TDM for amikacin and tobramycin. So this is the argument, and I don't think it's a cop-out as someone might have suggested before. I think there's a good argument for transitioning into to this change over time. And so there's good dose calculators in therapeutic guidelines. I had a brief look at them during the kind of writing process, but a couple of pharmacists come up already saying they find them very kind of useful and intuitive. So do have a look at those as well. So anyway, I hope that gives you some idea about some of the kind of considerations that went in. I suspect the next guidelines that I can anticipate it, but I expect gentamicin won't be there for Pseudomonas, but it's not that it's, anyway, I've said enough, but I'll stop.